Welcome back our fans. The initial lesion, stage I gingivitis, start 2 to 4 days. Vasodilation of various vessels. And increased GCF. Clinically, gingiva appear healthy. Considered a subclinical gingivitis. Microscopically, increase inflammatory infiltrate often migrate into the sulcus. Peravascular, collagen disappear and replaced by inflammatory cells. Post-response determine whether it resolve or develop to chronic lesion. Early lesion, stage 2 gingivitis. After about 1 week of plaque accumulation, the lesion developed. Clinically, erythema that attributed to vasodilation and increased blood vessels. Bleeding on probing is evident. Microscopically, increase inflammatory infiltrate with macrophages and T lymphocytes. Basal cells of J and SE proliferate as protective mechanical barrier. Rate PEG's proliferation and try to maintain function of epithelial barrier. Fibroblasts start to show cell damage. Early loss of gingival collagen in the infiltrated area that allows space for more infiltration. Some coronal epithelium lost allow for extension of plaque subgingivally. Early lesion, stage 2 gingivitis. After about 1 week of plaque accumulation, the lesion develop. Clinically, erythema that attributed to vasodilation and increased blood vessels. Bleeding on probing is evident. Microscopically, increase inflammatory infiltrate with macrophages and T lymphocytes. Basal cells of J and SE proliferate as protective mechanical barrier. Rate PEG's proliferation and try to maintain function of epithelial barrier. Fibroblasts start to show cell damage. Early loss of gingival collagen in the infiltrated area that allows space for more infiltration. Some coronal epithelium lost allow for extension of plaque subgingivally. Established lesion, stage 3 gingivitis. 1 to 2 weeks. Clinically, redness, swelling and bleeding. GM can be separated easily, giving rise to pseudopocket due to increased collagen destruction and edema. Increased GCF flow. Microscopically, inflammatory cells increase with plasma cells and increased migration of PMNS. J no longer attached to the tooth and transform to pseudopocket. This allow for more apical extension of the plaque. Epithelium ulceration. Reedy pegs extend further into CT. Fibroblasts continue to show cell damage. Loss of collagen continue laterally and apically allow for more infiltration. The key features to differentiate the established lesion is increased number of plasma cells. At this stage there is no apical migration of J. As the fibrous tissue is destroyed at the inflamed area, at distant site there is some proliferation. Hence, destruction and repair continue side by side, which affect the color and shape of gingiva. If inflammation dominates, so tissue is soft and easily bleed. If the fibrous tissue dominates, so gingiva can be firm and pink. However, swollen with little bleeding. Established lesion may remain stable or may become active and progress to periodontitis. Clinical manifestation: increased GCF production rate, bleeding on probing, change in color, change in surface texture, presence of plaque or calculus without RBL, change in consistency, easy retraction of gingiva, bleeding on probing, dilation of capillaries, ulceration of sulcular epithelium, change color into red, vascular proliferation, extravasation of RBCs into CT and breakdown of hemoglobin, change consistency into soft, presence of edema, alteration of ground substance, change surface texture, loss of stippling results from loss of attachment of collagen bundles binding attached gingiva to bone, easy retraction, destruction of denogingival fibers and circular, loss of tissue tone. Diagnosis: the key elements that lead to a diagnosis of gingivitis are visual changes of the dental gingiva, edema, erythema, bulbous papillae, signs of bleeding upon sulcular probing with periodontal probe, complete reversibility of the tissue alterations once the dental biofilm is removed. Gingivitis precedes periodontitis, but not all cases of gingivitis progress to periodontitis. Clinical significance: management of gingivitis is 1. A primary preventive strategy for periodontitis. 2. A secondary preventive strategy for recurrence of periodontitis. Management: both localized and generalized gingivitis should be managed by patient motivation, oral hygiene instruction, professional mechanical plaque removal, and implementation of self-performed mechanical plaque control. Dietary advice and tobacco counseling are recommended when indicated. Thanks for watching. Support us by likes and subscribes.